Okay, do you guys see the text?
Yes, doctor,
Hello?
we can see.
Okay, and do you hear me?
Yes, doc, we can hear you.
Great. So the purpose of this is to go through the guidelines of our unit protocol, and I think the best one would be the resuscitations. So we will do part of it each day until we finish it all, and that will give you a time to ask questions and to discuss whatever you want to discuss. So the purpose of this resuscitation is to understand and help babies transitions from intrauterine to extrauterine. Now, 90% of these babies will go smoothly without need for help, and 10% will need some help. When we say some help, meaning that anything but do not without providing positive pressure ventilation. That's what we call it, some help. And some will need intensive help. And when we say intensive help, mean active resuscitation. In another way, giving PPV. So some help, something like positioning, rewarming, suctioning, dryness, and cleaning, and stimulation. These are the some help. While the 1% will need in intensive or extensive measures, which mean active resuscitation. Now, for a successful resuscitation, at least there should be one physician, and at least should be one nurse. And both should have at least skills to help the baby. And whoever there, minimally they should know the resuscitation through NRP, and also they should be able to intubate, they should be able to do an IV and administer medication. There should be a list of devices available, which is mentioned in Appendix 1. We will go through it. Now, these devices, they need to have a registry book, and they should be signed every day or at least twice a week that they are available and they are functioning. So you don't want to go and do resuscitation and one of the machines is not working, which is, for example, the incubator, the ventilator, the CPAP, the oxygen supply, the laryngoscope, all should be signed and check mark, they are working. So these, what we call it, anticipation of resuscitation. We know 10% will need some help. We know 1% will need intensive help. We know that one physician should be available. We know one nurse at least should be available. And we know they should be able to do resuscitation, intubate, and do IV and give medication. And the equipment should be checked, should be available first, and should be checked that they are functioning. So we need, I don't know, we need like a registry or a book that to be signed by the nurses or by the OT also and by the labor room, that they, what are the list of the equipment that are available for resuscitation, including those for cardiology, those for respiratory, those for the IV. These are a list for warming, and so on, should be available and always checked, including the devices and also the medication that we needed during resuscitation. Now, ideally, each person attending the resuscitation should have NRP or analyst or any other related program that is certify that person, that healthcare provider, to do resuscitation. And ideally, this certificate should be renewed every 2 years. So we've talked about the purpose of this guidelines and the anticipation and the training. Now we'll talk about high-risk delivery. What's the meaning of high-risk delivery? It's the delivery that we expect that the transition from extrauterine to intrauterine life will not happen smoothly. We expect that. And the reason? For certain maternal or fetal conditions. And these are, there are many. Do you guys hear me? Do you hear me?
Yes, doctor. Yes, yes. We can hear you.
Okay. So these are the list will be mentioned in Appendix 2 at the end of this protocol. These are maternal and fetal. There are also antepartum, and there is the delivery complication. So there is conditions, there is complications. Conditions are maternal and fetal, and there is complication that happen antenatally and at the delivery. So what are the fetal conditions? Maternal condition, mom is more than 45 years and less than 16 years. Mom has a diabetes or hypertension, whether it's essential, whether it's a secondary, whether it's a pregnancy-induced, and the diabetes, type 1, type 2, gestational diabetes, all should be attended by, should be attended by a physician. Maternal substance use disorder, now this is not very common here, but also there is some psychological and neurological condition, maternal, that need some of these medications. So this would be applied here. If there is history of stillbirth, which is death, there is history of fetal loss, whether it's accidental or therapeutic, and there is an early neonatal death or death within 1 week of life. All these maternal condition, if it's alarm during history, should be attended. Now fetal condition, prematurity, which means babies deliver below 37. But only those delivered below 35 will need admission. Post-maturity, those born after 42 weeks of life. Any suspicion of malformation or any intrauterine growth restriction, that means the weight of the baby, of the fetus, is not going with the gestation of the pregnancy. If there is multiple gestation, whether it's a twin or triplet or quadruplet or pentaplet or hexaplet, these need to be attended. What are the antepartum complications? Any placental anomaly, placenta previa, placental abruption. And the reason is these can cause bleeding, and it can cause shock and anemia in the baby and hypotension too. If there is oligohydramnia, which means that there might be lung hypoplasia and the baby might need resuscitation, and there might be pneumothorax and so on, and might need ventilation, or polyhydramnia, there might be obstruction somewhere. Delivery complication, if there is a transverse lie or a breech presentation, or there is a severe chorioamnionitis. Now, how we know there is a chorioamnionitis? There is tender uterus, there is leukocytosis in the mother, there is fever, there is foul-smelling liquor leaking from the mother. All these can cause suspicion of chorioamnionitis. And the reason why we attend, because the baby might have sepsis, and this sepsis might be fulminant and might cause shock. So these are the list: foul-smelling liquor, meconium stain amniotic fluid, any antenatal asphyxia. And when we say asphyxia, the definition of asphyxia is a failure to initiate or maintain spontaneous breathing. So if there is antenatal suspicion of asphyxia, because asphyxia can happen antenatally, acute or chronic, intrapartum, and can happen postpartum. And usually we know the antenatal asphyxia from the abnormal fetal heart rate pattern. If the mom receiving narcotics few hours before birth, within 4 hours, if the mom received narcotic for pain, such as morphine, need to be attended. Any instrumental delivery need to be attended, whether it's a forceps or a vacuum, and of course all the cesarean section. If the fetus are compromised, these are the risk factors or high risk deliveries that need to be attended. These are the list. And now, in addition to that, when there is a high risk delivery, and if the time is enough, we, the team, and mostly the physician, should meet with parents, discuss the fetal conditions, and inform them, preferably by writing, any anticipated fetal or neonatal complications and outcome. And it will be a good time to answer parent questions, and that will help complaining, reduce complaining, and increase collaboration of the parent. The necessary equipment that should be checked every day in a book or a registry should be assembled prior birth of any high risk, these high risk. The most important, of course, these are radiant warmer, oxygen source, and remember, no oxygen in an ICU unblended. Oxygen always has to be blended, which means there is a flow and there is oxygen and there is a blender to control both the flow and the oxygen. Suctioning apparatus or equipment, whether it's a manual or electrical, and should be always functioning. Laryngoscope that is functioning with a good light. The ambu bag or self flow inflated bag should be checked with mask. And there should be always demonstration by holding the mask against your palm and then trying to inflate, which means will give you the sense of good seal. Okay, I think I have to stop here if you have any question. Any question? Yes? No? Neutral?
Yes, good.
Any question? No questions?
No, so far, doctor.
Okay, great. I will finish in 3 minutes, so 15 minutes is enough. I don't want to saturate people with information now. For preterm babies, there are other requirements. Why? Because preterm babies are prone to other complications. These complications, hypothermia. So how we control that and why the reason why this hypothermia, this needs a discussion. But mainly these babies have very high oozing from their skin. Their service area is very high and they cannot control their core temperature. So they need, for example, a certain plastic bag to prevent them from oozing and drop them. Need radiant warmers and need also, the most important is to control the room temperature. The maintenance has to be informed at least 20 minutes to 30 minutes before delivery to increase the room temperature up to 25 degrees Celsius. And the radiant warmer should be working and a plastic bag. And of course, incubators, if the baby can be inside the incubator because no need for any intermediate intervention. So these are very important to remember for hypothermia. And the hypothermia is way important than intubation and giving surfactant, because people, I know, they want to intubate and give surfactant. You know, this cannot be delayed. Surfactant can be delayed up to 2 hours. So surfactant is not that important. It's not an emergency medication. I need always to remember, surfactant is not an emergency medication. There is, for preterm babies, there is inadequate ventilation. There are many reasons. The lungs are not mature yet, deficient of surfactant, the rib cage are not very tough and pliable. All this make the preterm babies more vulnerable to inadequate ventilation. They are at risk of infection because of immune deficiency or immune prematurity. and they are exposed to organ damage. They can bleed in their brain, we can damage their eyes, we can damage their liver and cause bleeding, we can damage their bowels if we are not careful with the feed, and so on. So these are, and therefore additional resources are needed. So most of the time you need 2 doctors. For example, babies less than 32 weeks. You need at least 2 nurses because they are. Ideal situation, the charge nurse and the on-call consultant need to be called and notified before the delivery of any babies less than 32 weeks. Now, between 32 and 35 weeks is not, you can, but it's not 100% necessarily to call that. So any baby less than 32 weeks, the on-call staff should be notified before delivery if possible. The equipment to keep infant warm, raising the temperature before delivery, before starting. So no section of delivery and the temperature is cold, because it's more harmful than congenital malformation, the hypothermia. If the baby is less than 28 weeks, you need the polyethylene bag, the plastic bag. And the baby has to be wrapped inside that bag to maintain the temperature. Of course, a person skilled in intubation, especially the small babies. 30 weeks, most likely they may need surfactant, and the percentage around 50% of them will need surfactant. And therefore, a personnel should be available to deliver continuous positive airway pressure. Now, airway pressure through CPAP or nasal prong or nasal mask should be given to the baby within 2 minutes. There should be no delay. And the reason, because it will prevent stick and it will prevent further complication. I will prevent maybe the need for surfactant. So the most important here, in addition to the temperature, is giving CPAP. So remember, temperature, giving CPAP. Okay? And the CPAP is always need to be blended. So to give CPAP, you need air source, you need oxygen blender, and you need a monitor. So you need to monitor the oxygen to give. In babies less than 30 weeks, start with 30%. In babies more than 30 weeks, start with 21%, and then titrate up and down to maintain saturation above 91%. In term baby, above 94. In preterm, above 91. You should prepare the transport incubator before putting the baby inside. And especially if the our labor room is not that far, so you can scoop the baby right away if you don't have a ready-made incubator. But you can scoop the baby right away. So I'm going to stop here, Ren, if there is no question. And tomorrow we'll start from antenatal counseling.
Okay, doctor. Thank you so much.
Any questions?
Nothing, doctor. Thank you.
Is it good? Can we go like this, or you want another suggestion?
Yeah, like this, doctor, at least so that everybody, even their home, they can attend.
Okay. So tomorrow at the same time, we'll be doing the session 2, and I recorded this so anybody can hear it. I will send you the link.
Yeah, thank you.
Thank you very much. Bye-bye.